clarification would you like?
You mentioned a gate surrounding the perimeter. Were the guards located at the gate, or were they just outside the home?
Just outside the kitchen.
So there was nobody at the gate, actually, no physical person at the gate. And I'm sorry, the kitchen was how far, again, away from the bedroom?
Well, the kitchen was just downstairs. The guard gate was outside the kitchen.
Okay. Can you please re-ask the question?
Sure. Assuming that we have a relatively large house, an incident occurs on the upper floor. Down the stairs, there is a kitchen where there's a person working in the kitchen. You discover an emergency situation upstairs and run downstairs, and I want you to further assume that the house is totally guarded on the perimeter, that there are no landlines inside the house which you can use. Do you think that it would be unreasonable to ask a person in the kitchen to get security, to make arrangements for an ambulance to be able to get onto the premises?
Allow the question to be asked, but I'm going to sustain the objection.
I better start over then.
Okay.
Okay. We got a large house surrounded by a perimeter. Perimeter gates. No entrance to the house unless security approves it. We got an emergency upstairs. No landlines in the entire house. There's no way to get inside the gate unless security opens the gate. And you are concerned with attempting to rectify the emergency situation upstairs. There is a person in the kitchen, which is a very short distance away from the security trailer. Do you think it would be appropriate to ask that person in the kitchen to get help and to get security?
I think it would be more appropriate than leaving the patient for whatever period of time to notify security. I would, however, first, as I said earlier, attempt to resuscitate the patient before doing anything other than simply yelling or screaming out for help.
Well, assuming you do have an expertise at resuscitation, and would you expect a cardiologist to have such an expertise?
Indeed, I would.
Do you think that the cardiologist, upon discovering the situation, should make attempt to resuscitate or rectify or help the patient who's in distress?
I would hope that he or she would, yes.
And what's a reasonable amount of time for a person to make a preliminary assessment of what the problem is, and assuming it's the problem that we've all been discussing in this case, where you have a patient where his eyes open, mouth open, and not breathing, how much time would you think it would be appropriate to spend on that patient before asking for assistance?
Well, again, an assessment does not take a lot of time in that situation, but I mean, starting to give CPR should be initiated then fairly promptly in 1 to 2 minutes at the maximum, and I would say sustaining the effort for 3 minutes or so before you leave the patient to get help or make a call for help.
Why would you do CPR first before you made an attempt to call for help?
Just in case it was a sudden arrest that you just happened on, and the patient might quickly respond. So I think if you're trained in advanced cardiopulmonary life support and you're a cardiologist, you would hope that you could provide effective CPR, yes.
What type of CPR would you provide under the circumstances that have been described in this case? We have a patient not breathing, his eyes are open, his mouth is open, and you've made a determination that perhaps there's a thready pulse.
Well, single-person CPR could be mouth-to-mouth and compression. Of course, an ambu bag is what's recommended, but in when it's available. But again, as a first step to at least make an attempt to see if you could reverse the situation, I think it's not unreasonable to try mouth-to-mouth, although it's not recommended as a first step in witnessed cardiac arrest.
Now, with a thready pulse and the person not breathing and eyes open, mouth open, would you be able to make a complete diagnosis based upon those symptoms?
I would question if the patient was actually alive. Those are findings that often are consistent with death.
Well, if you add in the further hypothetical that at approximately 12:26, which is, in the area of 25, 26 minutes after the discovery is apparently made, a paramedic, in feeling for a pulse and feeling the temperature of the patient and making various observations, concluded that the patient had been dead for at least 20 to 30 minutes. Would that confirm your initial feeling that it sounds as though the patient were already deceased?
Yes, it would.
Tell me, doctor, in the event that the patient is deceased at 12 o'clock, is there anything that can be done that would involve additional help coming 5 minutes later to save a patient?
I believe it's unlikely.
In the event that you had prepared a chart of medications given during the evening, would that alter the outcome in this case?
Not if the patient was dead when you came upon him at around 12 noon.
Now, hypothetically, if you had given that patient propofol, slow bolus dose over 3 to 5 minutes between 10:40 and 10:50, would you expect that to have anything to do with that patient's condition at 12 o'clock?
No, I would not.
Especially in light of the fact that you've observed that patient for 20 to 30 minutes after giving the propofol injection. Would you have any reason to think that propofol had anything to do with the situation that you were now confronted with?
Sustain.
In the event that you'd given a slow bolus of propofol at 10:40 between 10:40 and 10:50, and stayed with the patient for a period of time such that you felt that the patient was resting comfortably, sleeping lightly, not sleeping heavy, not snoring, would you think that that patient had incurred troubles as a result of propofol?
Given that it was more than an hour had elapsed since the small, slow bolus injection was given, I would not have expected any effects at that time related to propofol.
If you give that slow bolus of propofol, in the event that propofol had an adverse effect on the patient, would you see that during the period of time that you were given that bolus over 3 to 5 minutes?
You would certainly expect to find it within 5 minutes. And typically, if you're giving it that slowly, you would observe actually even while you're infusing.
And after a 10 or 15-minute period of time, would you expect the therapeutic effect of propofol to be totally eliminated?
Yes, I believe I testified to that earlier.
In the event that you've passed that time?
Whoops.
Excuse me, sir.
If you could restart.
In the event that you had passed that time in which the therapeutic, you're sure that the therapeutic effect was gone, would you have any reason to believe that propofol was a factor in this case?
No, I would not.
Now, let's assume that you followed or went with the paramedics to, I want you to further assume that the paramedics have sought permission and have received permission to terminate resuscitation, basically to declare the patient dead. Do you think that by taking over treatment of that patient and convincing them to go on to the hospital, is it realistic that there's anything else that can be done for this patient?
Objection, a improper hypothetical.
Overruled. Do you understand it?
I believe you're asking me at the
Well,
point...
if you need to ask the
Okay.
question, then I'll sustain the objection. Re-ask it.
Okay, thank you, sir.
Sure.
Doctor, the paramedics have obtained authority via telephone after reporting their findings, their observations of no pulse, no breathing, no change in condition after 20 minutes, 25 minutes of treatment, and they've received permission to terminate the call that the patient is deceased. Do you think at that point in time, making further attempts by transporting the person to the hospital and doing further procedures to the hospital, there's a realistic chance of saving that patient?
I would say there was no chance.
Do you think that in the event that either the paramedics or the emergency room personnel, either or, at the hospital, were aware of the fact that earlier in the day, like at 10:40, 10:50, that the patient had received propofol, that would change their treatment procedures?
No.
Do you think it would have changed the outcome in this case?
Absolutely not.
Is there, would it be accurate to state that the only treatment for propofol, if there's propofol there, is time?
Well, propofol does not have a specific antagonist, that is reversal drug, in contrast to the benzodiazepines like lorazepam or midazolam or diazepam, which can be reversed by flumazenil. So the only treatment for a propofol overdose is just tincture of time, if you will. That is, you just wait for the drug to be redistributed and eliminated.
And if there is a propofol overdose, that is apparent right from the very beginning, isn't it?
Yeah, it usually occurs as you're administering or shortly thereafter and is related to peak concentrations.
And propofol goes from peak concentration to a very small concentration in a matter of how long?
Well, it's a very lipophilic drug, so it's rapidly initially distributed when given in the intravascular space intravenously according to the perfusion of the various organs. So it goes to initially, the majority of the drug goes to the organs that are most highly perfused, like the brain, like the heart, like the kidney and the liver. And then over a very short time, it's rapidly, we say, redistributed from the highly perfused organs, that is those that get the majority of the blood flow, to the less well perfused tissue, such as muscle, and then more slowly into fat. And then finally it's eliminated over a long period of time from the reservoirs in the fat where being a lipid-soluble drug, it gets into the fatty